Guys, genito-urinary system, there are plenty of stations, okay? Plenty of stations in genito-urinary, okay, system. Before I start, you know that this is a medicine case, yeah? But be careful because some questions that you ask in the structure, in the medicine structure, P1, P2, P3 maftosa, some questions I don't need here, okay? Plenty of questions in the structure I don't need. If you ask these questions, you'll only waste your time, okay? So first of all, if a patient is coming to you with pain while passing urine or abdominal pain, is it a counseling station or is it a medicine station? Medicine. You need to know, because in counseling, we don't take history. In counseling, we don't take history. So if a patient is coming to you with pain while passing urine or abdominal pain, it is a medicine structure. So I will use P1, P2, P3 and maftosa. But this is my structure, P1, P2, P3 maftosa. But in my structure, some questions I don't need to ask. Some questions I will tell you now, I don't need to ask, okay? So before I start the genito-urinary system, there are some principles. Some principles. If a patient is coming to you with abdominal pain, mostly lower abdominal pain, okay? So what is the presenting complaint? Lower abdominal pain or pain while passing urine. What will be my differentials? Number one, what will be my differentials? Number two, there are many questions that you guys don't ask. Like what? Like the cause. What else? Like the complications. So, if a patient is coming with pain while passing urine or abdominal pain, what are my differentials? My differentials, either kidneys, yeah? Abdominal pain. I don't know yet where is the pain, but I say abdominal pain. So what is here now? Abdomen, in the abdomen, what is here? Kidneys, yeah? In a female, the female genital system, yeah? What else? In a female genital, and in a male, there is prostate and the stomach and the bowel, yeah? So here there is kidneys or in a female and in a male. The prostate in a male and the genital organ in a female. And the kidneys. What else we said? Stomach and bowel. Guys, just think of it like this. So you don't exhaust yourself in differentials. Think of it like this. Hi, how can I help you, doctor? I have tummy pain. Tummy pain. So, I'm thinking of kidneys, stomach, in a female genital system, but in a male, prostate. Yeah? What are the symptoms that I will ask if a patient is coming with abdominal pain or pain while passing urine? If it's abdominal pain, we know. What is the presenting complaint? So P1 is abdo pain, yeah? So what is the most important thing I will explore here? Guys, you need to know abdominal pain. Where is it exactly? This is the presenting complaint. Site, doctor, it's in my lower tummy. Does it go anywhere else? No, doctor. Type of pain? Anything that makes it better? Anything that makes it worse? Have you taken any medication for it? That's if the presenting complaint is abdominal pain. What if the presenting complaint, pain while passing urine? That's the complaint. Or pain while passing urine. Pain on passing urine. So, what is the word? Urine. So you need to know, first of all, explore the pain while passing urine, since when, how does it start? And then urine, color, urine, smell, blood in urine. Okay? So don't forget, if the complaint is urine, you need the urine, color, urine, smell, what else? Blood in urine, blood in urine, plus explore the pain while passing urine. When, how, okay? So this will be my presenting complaint, either abdo pain or pain while passing urine. And now, you will start, after exploring the presenting complaint, your differentials. So your differentials, and your differentials, as I mentioned, it's either kidney or stomach or the female genital or the prostate, yeah? So what can you ask in the stomach? or the bowel, pain, coming abdominal pain, what can you ask? You can ask nausea, vomiting, diarrhea, constipation, fever. That's it. So 5 questions, they come together. Yeah? Nausea, vomiting, diarrhea, constipation, fever. Clear? They come together. Any nausea or vomiting, no doctor. Diarrhea by any chance, constipation, no. Fever. What can you ask in the kidney? If you are thinking of kidney problem and that's what's causing the pain, what can you ask? You can specify the pain. Low into groin, yeah? Number 1 specify. Is the pain low into groin? Number 1, number 2. So the pain specify. Is it low into groin? What else? And we said urine, what? Color, urine, smell, blood in urine. Blood in urine. So when you see the kidney, remember one word. Urine. Urine. Many doctors, they forget to ask about the color of urine, the smell of urine, you understand? Blood in urine, urine. What if the female genital system, what would you ask if a patient's coming with abdominal pain? Guys, as if we explored the pain, STI, number 1. So you can ask about any discharge. Okay? You cannot go there, you cannot leave it. Any discharge from the front passage. What else? You can ask about pain during the period, pain during sex. Why? PID. So, female genital organ. You will ask discharge. You will ask pain during period and pain during sex. You can ask what else? Sexual history. Yeah? Is it important? Yes. Sexual history. Sexual history. Are you sexually active? By that I mean do you use condom? Do you practice safe sex? Sexually active, sorry. Do you practice safe sex? By that I mean do you use condom? Do you have a stable partner? So sexual history. Pain during the period and pain during sex. Discharge. Okay? So 3 questions and move on. If you don't think it is the cause, don't go there in details. Now the prostate. The prostate, what questions can you ask? Prostate, BPH or cancer? What are the questions for BPH? What are the questions? The questions are number 1, he can't start. He can't start. He cannot initiate. So do you find it difficult to start when you go to pass urine? Now when he goes to pass urine, what happened? Weak stream. Then at the end, terminal dribbling. 3 questions. Okay, so difficult to start, weak stream, terminal dribbling. And you can ask about frequency and nocturia. Okay, frequency, you go to pass urine more often than normal, and nocturia, you go in the middle of the night. I said BPH and cancer. Cancer, weight loss, back pain. Done. Cancer is
weight loss.
You ask about weight loss and back pain. That's it. By these 2 questions, we excluded. We didn't really exclude cancer, but there's flaws. You know flaws, loss of appetite. Yeah? So guys, in this structure now in P1, how many stations have we covered? Plenty. Okay? Plenty of stations. Like BPH, the presentation is problem in urine. Yeah? So you can ask about, again, urine, color, smell, blood, frequency, yeah? Urgency, weak stream. Then, a female, lower abdominal pain, don't forget. Sexual history, discharge, pain during period, pain during sex. If it's coming with urine problem, so always urine problem. So always ask about urine, color, urine, smell, urine, blood in urine. Yeah? Then, if it's coming with abdominal pain, you can include the bowel, nausea, vomiting, diarrhea, constipation. Okay? These are your differentials. But, do I need to ask all of them in every station? No. What do you mean no? I mean if the patient, Dr. Fatima, if the patient is coming with you with, doctor, a male patient is coming with, doctor, pain while passing urine. So, what is the presenting complaint? So when I give you these differentials, use it smart. What do I mean by use it smart? How can I help you? Doctor, I have pain on passing urine. So which system is that?
Kidney.
Then, can you please tell me, when did that happen? Anything that makes it worse? Anything that makes it better? Yeah? And apart from the pain, can you please tell me anything else? Like, tell me like what? Changing the color, changing the smell, do you notice any blood? So which system? Urine. And once, there is something common very important. Once I know that this is my system, yeah? He's got low intergrowing pain, he's got pain while passing urine, he's got some blood, this is my system. What you must mention? Risk factors and complications. Oh, we forgot about them. We always forget about them. So whenever you know that the station is going somewhere, don't forget to ask about the cause of the problem and the complications. I will tell you and I will give you some examples. What do I mean by the cause and the complications? Today I'm talking about genito-urinary. I'm not discussing GIT. But if I'm asking the patient, how can I help you? Doctor, I have pain while passing urine, presenting complaint. I started exploring the pain while passing urine. Okay? And I started asking about the color of urine. Doctor, there is some blood in it. Okay? And when I go, I struggle to pass urine and I have pain and the pain is low to groin. What do you think you are going towards? Stone. What do you think? Stone. Okay? Low to groin pain. Okay? I struggle when I go to pass urine, there is pain there. Sometimes there's blood. Stone. Now I know I'm going towards stone. But I need to know the cause and I need to know the complications. That's my point. The cause. What causes stone? Lifestyle. Sorry? Yeah? Dehydration. The patient doesn't drink plenty of fluids. Sometimes family history. Sometimes some stones are metabolic. Some stones are metabolic. So family history. Okay. What could be the complication of the stones there? Anuria. Anuria. The patient might be blocked. Stones, both ureters or stone at the end just before the bladder, and then the patient is not passing urine. So you always ask, when was the last time you passed? Urine. Because think about it, stone is blocking the pathway. So always ask, always. It's a red flag. When was the last time you passed? Urine. Because maybe this patient, there is a stone that's blocking the whole pathway and he doesn't pass urine. Okay. For example, if the patient is coming with UTI, with what? How can I help you? Doctor, I have pain while passing urine. Anything else? Doctor, it's stinging. Doctor, I'm feverish. Doctor, all these kind of symptoms for UTI. So now I know that I am in this system, UTI. However, do I need to only diagnose or do I need to find the cause? The cause as well and the complications. So for any case, guys, please, you are not only here to diagnose, which 90% of us forget. Well, from the information you're giving me and according to the examination, you have UTI. However, doctor, why do I have UTI? Then you stop. Oh, I forgot the question. Wiping, back to front or front to back, perfume, you understand? If you use the shower or bath, and then it's not really nice when you ask it later after he asks you. Because you need to know. So my point is, less differentials, but more focus into the cause and the complication. So if a patient is coming with pain while passing urine, female coming with pain while passing urine, explore. When did the pain start? How did it start? All of a sudden, gradual. When did you last pass urine? Apart from this, anything else? Like what, doctor? Like any fever? Ah, yeah, doctor, I feel my body's, having some temperature. Now I know I'm going toward an infection because fever equal infection. But after that, I'm thinking of UTI. So after that, what are the differentials you're gonna think of? What are your differentials if a patient is coming with fever, pain while passing urine? Will your differential be GIT? Will your differential be if it's a female? female genital system. What do you think? Female genital system, that's it. So your only differentials in this case will be kidney and sexual history. Why sexual history? Because maybe there is discharge from the front passage, maybe there is an infection as well. Are you following me?
Yes.
You're not gonna go into too much details about abdomen, nausea, vomiting, or diarrhea, and then you go to no. Female, pain while passing urine. So my differentials, kidney and done. These are my differentials. However, more important is if I'm suspecting UTI, pain while passing urine, UTI, I need to know the cause. The cause, why is she having it? So I need to ask about the lifestyle, like wiping, is it back to front? Okay, like you have shower or bath, underwear, tight, you understand? So always ask about the cause. And complications, what can be the complication for UTI? Pyelonephritis, so rigors, shivering, you understand? Temperature is very high, sometimes like 39, 40, to exclude pyelonephritis. Do you understand me?
Yeah.
Because many doctors can have a UTI station without excluding pyelonephritis, without asking about the cause. They only ask about the cause when I say, doctor, why do you think I have it? Oh, can we please have some questions about the lifestyle? And it doesn't sound good. But if you forget, you'll ask that way. But you need to ask the cause and the complications. Okay? So now, guys, are you lost?
No.
And by the way, if you have an abdo pain, GIT, like gastroenteritis, for example, just a quick thing. For example, how can I help you, doctor, have abdominal pain? When you explore that, when you ask about anything else, that's not genito-urinary. But I will just recap something quickly to show you the importance of risk factor and complication. Anything else, doctor? Vomiting. Vomiting, doctor. Anything else? Diarrhea, doctor. So, vomiting, diarrhea, fever. You are asking about gastroenteritis. Right away, if a patient is coming with vomiting and diarrhea and fever, GIT, would you ask about any discharge from the front passage?
No.
You know now, you don't need the female genital. You know, yeah? You can't ask about the kidney because, again, kidney problem can cause vomiting. You can, but you're not going to go into details. Any problem passing urine? No, doctor. That's it. That's more than enough. But your main focus will be GIT. But then, why is he having gastroenteritis? Why? Can it be eating out? Can it be contact history? So that's the cause. But what can lead to too much vomiting and diarrhea? Yeah, complication. So that's very important for me. And it should be very important for you. The problem, but what causes it? Because I will tell this man, I will advise about eating out, I will advise about contact and having some time of work, and I will also safety net them about dehydration. That's how important the cause and the complications. Anyway, genito-urinary, a patient is coming with pain while passing urine, or a patient is coming with blood in urine. It could be a presenting complaint, hematuria, okay? So my problem is, which system I will focus on is the kidney. Clear. Now, if the presenting complaint is blood in urine, if the presenting complaint is what? So we know now, blood in urine, which system? Kidney is not genital mainly. I will ask, could be cervical cancer, and there is bleeding of the front passage, and I will ask like somehow few questions. But my main focus, blood while passing urine, my main focus is kidney, ureters, bladder, in a male and a female, and most commonly it comes to a male patient. So if the presenting complaint is blood in urine, what could be my differentials? Look, I said blood in urine, which system? Which system? Genito-urinary, yeah? Genito-urinary, blood in urine, genito-urinary, yeah? So, all over the way, in the kidney, in the ureters, in the bladder. Kidney, ureter, and bladder. What do you mean? Kidney, infection.
Trauma.
Trauma. no, the trauma coming out. You understand? Trauma, I mean, it will come, but I'm saying
trauma
most common trauma procedure. It's, you understand? So, kidney, ureter, bladder. In every single point, 3 points, yeah? Kidney, ureter, bladder. In every single point, I will exclude infection, stone, cancer. That's it. What? Infection and? Stone and?
Cancer.
Can it be caused by kidney stone?
Yes.
Can it be caused by pyelonephritis?
Yes.
Can it, that pyelonephritis infection?
Yes.
Yeah? Kidney stone? Stone. Cancer. Can it be called renal cell carcinoma? For example, blood. So come to the ureter. Ureter. Can it be caused by stone? Yes. Can it be caused by cancer in the ureter? Yes. Can it be caused by infection? Yes. Lower UTI? Yeah? Can cause. What about the bladder? Bladder cancer, yes. Infection, stone. Yeah. So you tell yourself, I'm thinking of 3 things. Blood in urine, infection, stone, cancer. So when you talk to the patient, be careful because you need to look at the patient's eyes, but you are thinking. I'm looking at her eyes now, and I can see in her eyes. I'm talking, giving her eye contact. Guys, you understand? Yeah. That's a trick. Give her the eye contact, and her face is like the board, for example. Seriously. Her face is the pictures is on her face. Yeah, okay. How can I help you? Doctor, I have blood while passing urine. So I'm looking at, can you please tell me more about it? So what is the presenting complaint? Blood in urine. Can you please tell me more about it? Well, doctor started 2 weeks ago, and it's increasing, and this and that. Okay, I explored the complaint. Then, on her face, kidney, ureter, bladder. So, I will start asking. By any chance that you feel that you lost weight recently? No, doctor. Your appetite decreased? No, doctor. So, that's cancer everywhere. You understand? Because cancer everywhere is weight losses, you know? Then, any fever by any chance? Rigors? No, doctor. Have you been diagnosed in the past that you had, anybody told you that you've had stones or pain while passing? No, doctor. So you are looking at her face and thinking. Don't ever do this. Any pain while passing urine? No, doctor. Any fever? That's what sometimes we do because we think and we don't give eye contact. Yeah? So, we said, what are the causes of hematuria? After we explore hematuria, what are the causes? Kidney, ureter, bladder. Everywhere, I'm thinking of infection, cancer, stone. And I told you, cancer everywhere, flows. Infection everywhere, fever. Guys, one question, fever. Fever, yeah? Stone is loin to groin. When did you last pass urine? Okay? What else for the hematuria? What other causes? Procedure. What? Procedure or trauma. Why? So I'm going down, yeah? Procedure or trauma. Procedure or trauma as a cause of hematuria. What else can cause hematuria? So up to down. Kidney, ureter, bladder. Everywhere could be infection, stone, cancer. When I go out, it could be trauma or procedure. What else?
Medication.
Perfect. Medication, blood thinner, or bleeding disorder. So medications, blood thinners, or medical condition, bleeding disorder. And you can even ask a medical condition like kidney problem. And that's it. That's all your differentials and questions. And then when you come down, P2, P3 mastosa, please be smart. What do I mean by be smart? The patient DESA is plus or minus, guys. What do I mean by DESA plus or? Not every patient I will ask DESA. Not every patient I will ask diet. Not every patient I will ask diet. So if a patient is coming with discharge from the front passage,
No.
would you ask diet?
No.
Would you ask exercise? No. Smoking? Yes.
Maybe yes.
Alcohol? Yes. If a patient is coming with pain while passing urine, how's your diet? What will diet do if you're thinking of pain while passing urine, UTI? What is the relationship between diet and UTI? If you are thinking of UTI, okay? If the patient is coming with bleeding from the front passage, would you really ask smoking? No, you will ever. I was just tricking. I was tricking. I always tricking. He's always here, and he's my, you know, huh? Yeah. And I always do this to him. Would you really ask us smoking? No, no, you won't ask us smoking. Smoking, blood, cancer, smoking, blood. First thing I'll think of, cancer anywhere. First risk factor, smoking. Okay, so that's my point. Use data smart. Maftosa. In these cases, maftosa, occupation and social is not really important. Guys, you need to take your history in 3 minutes, 4 minutes. History, literally, no more than 4 minutes. History is not 6-minute bill. 4 minute history is done. If a patient is coming with pain while passing urine and fever 2 days ago, how is it affecting your life? It has not yet affected my life. How is it affected? Has your daily activity been affected? Not yet. Why would you ask? Psychosocial in a complaint that's 2 days ago. You understand me? Use your time for management. Okay? For example, if a patient is coming with discharge from the front passage, use your time. A patient is coming with discharge from the front passage. We all explore the discharge using a track. When, color, yeah, any blood. But we never talk about risk factor. Like this discharge, what can cause it? This discharge, complication. So any patient, female who's coming with discharge from the front passage, I should think of complication PID. Do you agree? So always use your time smart. Always tell yourself, I will think all the time of cause and, please, complication. Cause and complication. In the mocks, I noticed that not many of us think of cause and complication, but plenty of us ask Desa Maftud blindly. No. Okay? Now, we will take a station by station, STEM, positive management. STEM, positive management, okay? But now this is the structure, this is the design for any pain while passing urine, for any stone, for hematuria, okay? For BBH, questions, cancer. What is the difference between BBH and cancer? A male is coming with frequency. A male is coming with frequency. Could it be BBH? Could it be cancer? Simply. How can I help you? How can I help you? Doctor, I pass urine more often than normal. Okay, can you please tell me more about it? When did this happen? Is it like continuous, or do you think comes and goes? Increasing, decreasing? Then go for the other questions. Weak stream and thermal dribbling, difficulty in starting, fever. Don't forget fever. Huh? Any problem in the urine, this fever. Okay, and then that's BBH. Then I need to exclude cancer flows. That's it. This is my history. Later on, you can ask whatever, but you should be specific. Guys, specific. Okay, relevant. So when you have patient with such symptoms, would you ask about diet? Exercise? No. But smoking? Yes. Family history? Yes. Clear? And your history should finish quick. So yes, I know P1, P2, P3 maftosa, but I'm not going to ask everything. My main concern is P1, explore, few differentials, flows, and then I will select. Clear? So, in the genito-urinary, I will discuss epididymoorchitis, and I will discuss testicular torsion. Testicular torsion. So far, it has not appeared in any exam, but I think it did appear, but people don't really pick it. I'm telling you, so far, there is no testicular torsion, but I believe there is. But nobody really, paid attention, because testicular problems, 90% of doctors, they get 000, 111, 110, and everybody, but nobody ever said, well, there is testicular torsion case. No, there is. There is. It is the most important question in PLAB 1. You cannot have PLAB 1 exam without testicular torsion. Either urgent surgery or, you know what I'm talking about, PLAB 1.
Yeah.
PLAB 1 is the most common question in PLAB 1. But in PLAB 2, nobody did say yet there is a testicular torsion. Question, but I think it appeared in the exam because. So always please, if a patient is coming with, I will discuss it in details, but if a patient is coming with, how can I help you? Doctor, severe pain in my testicles, or I have pain in my, he can say pain in my testicles without showing you the severity, without telling you very severe, because they don't want you to catch it.
Yeah.
Do you want to see, are you safe? Do you have basics in your brain? Any pain there equal torsion.
Yeah.
Then you go, all of you, any fever? No. Any discharge? No. Then doctor, maybe it's a cyst. Maybe no. Always think if there is testicular pain, it is torsion until proven otherwise. Torsion. Torsion. Okay? And always if a patient is coming with testicular pain, you need to do scan, ultrasound. Any testicular pain, ultrasound. Why? To exclude torsion. Guys, clear?
Yes.
All the time. Okay? And all the time, even you can mention it, and say, would like to exclude a condition called testicular torsion. By the way, testicular torsion can come with the case. The patient can present with pain ongoing, coming back and forth. It doesn't mean that it's just that severe pain in your head. No. There is intermittent torsion. Torsion on its own, back again. Torsion, back again on its own. So please think of torsion whenever there is testicular pain. Anyway, that's torsion. And you only say one thing. Only say one thing. How can I help you? Doctor, pain in my testicles. What's the first thing you do? Pain in my testicles. Socrates. Socrates. Then, pain in my testicles. What is the first question after you explore Socrates? After ask Socrates? Any fever?
Trauma.
Any fever, yeah. Any trauma? Clear. Guys, logic. Pain in my testicles. Fever, trauma. Discharge from your penis, no, front passage. Penis. Yeah. You understand? So, if a patient is coming with discharge from the front passage, from the penis, contact history. She says front passage, I said front passage after. You know, if a patient is coming with testicular pain, discharge, then think of infection, fever. So, epididymoorchitis is your first differential. But only pain, torsion is your first differential. Pain and fever, epididymoorchitis. And if it's a pain and fever, what is the most important history? If a patient is coming with testicular pain and fever, sexual history. Sexual history, STI. Sexual history. Okay? You cannot pass the station without sexual history. What else if a patient is coming with discharge from the penis and pain? What else can you ask about? UTI symptoms. So UTI and sexual history. You understand?
Yes.
And in management, what are the questions that must, or the things that must be mentioned in management? STI screening, urine sample. Clear, guys, like basics. You can mention an investigation one or two words and pass, and you can mention investigations like 15 words and you don't pass. So, doctor, discharge from my penis, swab, urine test, routine blood for infection markers, STI screening. How many words did I mention? 4. And you want to add ultrasound, scan, done. This is your investigations. Doctor, pain while passing urine. Pain while passing urine, investigation, urine sample, dipstick, urine culture, bloods. That's as far as you do. Doctor, a female discharge. Swab from the discharge. Blood. Urine or not? Yes, urine.
Yes.
Pregnancy test. If the period is like, yes and yeah. So simple investigations in these cases, which we forget. If a patient is coming with blood in urine, what are the investigations that you will do? Again, not the CT scan and the scope. No. Urine test. dipstick, culture, blood test, and later on you can talk about CT scan and yeah, ultrasound scan and basics first. Okay, first station. You are an FY2 doctor in the emergency department, 25 years old, presented with lower abdominal pain. Take history, further management. So 25 female coming with lower abdominal pain. So P1 abdominal pain, explore. Well, guys, 25 years old, presented to the A&E with lower abdominal pain. This is the first case. All these are the cases that we want, yeah? Lower abdominal pain, 25 female. Don't exhaust your head with scripts. Lower abdominal pain, start Socrates. Site, onset, how does it start? Character, P1, abdominal pain, yeah? Character, radiation, does it go? Please, full Socrates. You don't ask wallahi full Socrates. It's very hard I hear from someone, Socrates properly. No, you don't. Please, Socrates properly. Because with Socrates, you will get differentials. What do you mean by that? With Socrates, you will get the differential. How can I help you, doctor? I have lower abdominal pain. A female. Are you in pain right now? Please always start. If a patient is coming with pain, are you in pain now? Are you comfortable talking to always? Chest pain? Are you in pain now? No. Angina, stable angina. I'm in pain now. Could be MI. Shortness of breath. Are you short of breath now? No, doctor. It could be exercise induced asthma. But yes, he's short of breath asthma. You understand? So always if a patient is coming with a complaint, ask about it. Now, doctor, I'm dizzy. Are you dizzy now? No, doctor. That was last week. Now I'm fine. Doctor, I have whatever. Complain. Always start by right now, because right now it will give you differentials. Okay? Anyway, so how can I help you? Doctor, I have lower abdominal pain. P1. P1 is lower abdo pain. Socrates. When you ask Socrates, make sure you will do differentials. What do you mean? Can you please tell me, can you please point to one finger where the pain is? Doctor, it's in my lower abdomen side. Do you think it's loin to groin? Do you think it comes from your side to the, now, the side to exclude? Stones.
Yeah.
Side. Onset, all of a sudden or gradual. Character, what type of pain is it? Stabbing pain, dull aching pain, anything that makes it better, anything that makes it worse. Have you had this pain before? Have you taken any medication for it? No. Lower abdominal pain. Now, differentials. A female, 25, lower abdo pain. First differential. So, before the differential. I'm looking at her I'm looking at her eyes. But in her eyes, I can see stomach and bowel. I can see kidneys. I can see female genital organs. So, 2 questions. Any nausea or diarrhea by any chance? No, doctor. Fever? No. Done. How many questions?
3.
A whole system gone. Okay? Lower abdominal pain. So I will ask her about the stones or the urine itself. Kidney. I said in kidneys and ureter. One word to remember, which is urine. So any pain while passing urine by any chance? The color of urine, smell of urine, blood in urine, gone. Then you understand?
Yes.
System. And if you find something in urine, then stop. And that's it. That's your station. Stop. So in this case, the presenting complaint is yes, pain while passing urine. Yes, change in the color of urine, cloudy. Yes, smells. So now I'm thinking of UTI. Stop, and that's it. That's it. Risk factor, complications. Clear. Right there and then. Risk factors. What are risk factors? What are the risk factors for UTI? Hygiene. So wiping. Back to front. Number 2 cause. Bath. Bubble bath. Perfumed. Number 3 cause. Underwear. Tight underwear. Yeah. So things like this. Yeah. And fluid. If the patient's not drinking enough fluid, again. You understand? So now this is the risk factors. And what comes later? Complications. Rigors, feverish, very high fever. Okay? And sometimes ask her, yeah, when did you last pass urine? Because anuria. Done. Complications. Clear? That's it. Now, if you want to ask more differentials, feel free to ask just one more. Sexual history. Sexual, yeah, pain while passing urine. It could be STI. So sexual history. Any discharge from the hunt passage. Sexually active. Do you practice safe sex? By that I mean the use of condom. And sexual partners. Clear? That's it. History is finished. P1 differential. P2, have you had this before? Any medical condition and move on. Don't ask about the 5 medical conditions. Are you normally fit and well? Why do I need to ask the one question and move on? Because she's 25 years old.
Yeah, she's young.
So are you normally fit and well? That's it. Yes, doctor. Move on. Don't say like this, like any blood pressure, any cholesterol. Yeah. No. Are you normally fit and well? Yes, doctor. I am. Move on. Clear. You don't need to ask the conditions. You will waste your time. Then P3, DASA. In DASA, you need smoking and alcohol. Done. Diet? No. Exercise? No. Smoking and alcohol. Then Meftosa, are you on any medications? Allergy, family history, move on. That's your history. No occupation and no. That's it. Clear, guys. Clear, cutting history short. Relevant history. Okay? Now, management. Management, first of all, after history examination. Verbalized examination, observation and tummy. Okay? Provisional diagnosis. What is the diagnosis? Infection in urine. Okay? Management. Guys, simply, please, whenever you are managing any case, please, first thing, think of the 7 steps, please.
Yeah.
Because you will miss your management. And I don't know if how many of you had mocks and how many of you forgot investigations. Very common thing to forget the whole investigation, by the way. We forget the whole of it, yeah? So whenever I reach management, so number 1, does she need admission? No. It is a GP or A&E kind of home, unless it's a pyelonephritis, no admission. Number 2, senior. Number 3, what is the 3rd step? Investigation. Whenever you think of investigation, always blood, urine, stool, image. Always. I will remind you, trust me. It will remind. Many doctors have UTI and they don't do urine domestic. Always. Whenever you reach step 3 investigations, always remember blood, urine, stool, image. Blood, all bloods, routine bloods, infection markers, clear? Urine, domestic, and they will send culture. Stool, no. Image, scan. Done, jelly scan. Yeah? That's it. So blood, urine, stool, image. Then what's step 4?
Medication.
Symptomatic.
No. Symptomatic and
Lifestyle.
guys, always remember symptomatic and lifestyle. Symptomatic, is she in pain? Yes, pain or person, painkiller. And it's an infection. What to give? Antibiotics. Do I need to mention antibiotics? No.
No.
Antibiotics. I said symptomatic and lifestyle. Lifestyle. Bubble bath, plenty of fluids, if it's tight underwear, and what else? Wiping, what else? Sex. Guys, when they have UTI, I always advise them no,
Safe sex.
to avoid sex until it's treated, please.
Okay. During treatment.
Okay, so during the treatment, avoid sex. Alright? And always what to safety net for? Safety net for pyelonephritis and sepsis. Okay, all that if you feel feverish, if you feel the rigors, not passing urine, tired, lethargic, don't come. Yeah, if you are in the GP clinic, go to the hospital. Yeah, if you are in the GP clinic, don't tell the GP clinic if she rigors.
Go to the hospital.
Any. But if you are in the NE,
Come to us.
okay. And finally, you can advise her things that you do, things that you don't. And both are the opposite.
Of course.
What do you mean both are the opposite? Things that you do, they say in the NHS website, do and don't. And they say, do drink plenty of fluid. Do have the underwear, not tight underwear. Do shower. And then when they say don't have a bath. Don't have tight underwear. So guys, it's just not time. So it's in one phrase. Seriously, in the NHS, do and don't are the opposite. And they write them in 1 page or 2 pages. You don't need to. Okay? And when you advise about risk factor, be smart. What do I mean by be smart?
Choose her risk factor.
You remember the epilepsy station?
Mm-hmm.
10 years old Anna, her mom is bringing her. Don't haphazard tell her, don't take her swimming.
Check her hobbies.
Don't take her, why shouldn't I ask? Don't take her swimming. Why? Maybe doctor, I'm from a village. We don't have a swimming pool, doctor. We swim in the village, in the canal, you understand? So always ask about what does she like doing
What the risk factor?
in her free time. Doctor, in her free time, she plays in the dust. Maybe there is no swimming pool, maybe they play, you understand? So this is the same. Don't say to her, well, I highly advise you if you can wear, loose underwear. You understand? Doctor, I always wear, she can say to you, I always wear my dad's underwear, doctor. I don't have to. So always advise about what she has mentioned to you. Please, guys, because it's very scripted. If you keep talking about things that she doesn't have. Are you following me? That's why with the epilepsy, I mentioned the epilepsy station, because everyone says, don't take her to a place where there is flashing light. I don't. Well, don't take her swimming, and if you do, speak to the swimming instructor. We don't. And then when they say, move on to the next station, she tells you, doctor, but Anna, she likes doing such and such, which you didn't ask about. So you're advising her about what she doesn't. No, ask directly. What does she like doing? Then she will tell you 2 factors. Because in epilepsy, for example, there are 10 things I advise, but only 2 things that she has. So would you like to start with the 10 things, and you will be very unlucky if the 2 things that you want to advise her are at the end? Or would you like to ask her general question? What does she like doing? Then she will tell you, she likes to go to birthday parties, and she likes this flashing light, and she likes to go swimming. Then advise her about them. Anything else? No, doctor. Your station is finished. But what if you want to advise more? Advise more, but as long as you addressed what she does, that's my main concern. Clear? Next station. Next station, kidney stone. Yeah? You are an F1 to doctor in the emergency department. 45 years old, Andrew.
Is this thing closed at 5?
Are here, if they close them, it's fine. I'm happy. I'm gonna be here till like the morning. No, don't worry. You are an F1 doctor in the emergency department. 45 years old, Andrew, male, presented to the hospital with abdominal pain. Take history, discuss treatment. This case is kidney stone. How can I help you? Doctor, I have abdominal pain, doctor. Presenting complaint is abdo pain. First thing, do you want to ask Socrates? Guys, very important. What is the pain? He will tell you, doctor. Loin to groin. Yeah? Anything that makes it worse? Anything that makes it better? Have you taken any medication for it? Did it help? Have you had this before? Please. The new course, I have not mentioned plenty of times about exploring the presenting complaint. I just say it once and move on. Yeah? So but in the older course, I've mentioned it plenty of times and we still don't mention it. Presenting complaint. After explore the abdominal pain, the patient will give you loin to groin, and the patient will say to you, comes and goes. Episodic, comes and goes. Okay? Now you know you are thinking of stone. Ask about what?
History of stone.
No. Before that, first of all, I looked at her face, and she's coming with he's coming with lower abdominal pain. Then, in her face, GIT, kidney,
Prostate.
and the female genital organ.
No.
But his name is Andrew. So instead is the
Prostate.
prostate.
Yeah.
Yeah? I said either or. You cannot have both in the same station. Either female genital or prostate. So I looked at the face and I will ask as simple as any vomiting or diarrhea or fever. No. Move on. Move on. Don't say any constipation. Move on. Then any problem in urine. Open question. Open. That's it. Yes, doctor. Sometimes I notice some blood in urine. Can blood in urine come with stone?
Yes.
Yes.
But in this case, he made it more difficult because you will merge cancer as well.
Yes.
You get me?
Yeah.
Anyway, so yes, doctor, I have pain while passing urine, and I also have blood in urine. So, blood in urine, explore. When did it start? How did it start? You understand? Apart from this, anything else? No, doctor. Any fever? No, doctor. What about the smell of urine, color of urine, because I said to you, in the kidney, I remember one word. What is the word, doctor? Urine. Kidney, urine. Smell, color, blood, pain while passing urine. 4 things: color urine, smell urine, pain while passing urine, blood and urine. Then you found what you want. You know it's loin to groin. You know there is some bleeding there. You know that it comes and goes. Now you think of stone. Now, stop. Should I go to prostate? Not now. Why not now? Prostate is differential, because I said either or, but not now. Once I think of once I think of diagnosis, cause and complication. So you don't forget. Stone causes diet, some food, some types of food can be a risk factor, or sometimes if you don't drink plenty of fluid, risk factor. Family history of stones. Okay, so always stop and ask. So in the stones, you always think of dehydration. You don't drink plenty of fluids. Always think of some type of food like chocolate. Eating too much of chocolate can lead to increase in the oxalate stone, some type of stone. Okay, always think of family history, because sometimes it's hereditary. Okay, after that, risk factor. Should we go to prostate? No, complication. Because once you reach your diagnosis, before you give one more differential, cause complication. One complication, aneurysm.
Last time you went to the
When did you last pass?
urine.
Wallahi, you see, simple question. One word. Big meaning. Aneurysm. When did you last pass urine? Doctor, half an hour ago. Beautiful. Not say beautiful, yeah? Just I'm telling you beautiful, so safe. Then you can ask about prostate, frequency, how often, urgency. Then if he's old, have you noticed any weight loss by any chance? No. And then move on to medical condition. Have you had this before? P3, what is P3? DESA. In DESA, I already asked about diet as a factor. Exercise. Exercise can lead to Why can? What is the complaint? What is the complaint? I said he gave you pain while passing urine, and he also gave you bleeding. By the way, vigorous exercise can lead to bleeding. Okay. Anyway, you can ask about smoking, yes, and then move on to maftosa. In maftosa, do you need all of it? No. Medication, family history, and family history already asked as a risk factor. That's as quick as you can in history. Then examination, verbalized examination. You're not gonna examine in this case. Okay? So verbalized examination and observation and TOMI. So what are the examination that you verbalize? Observation and TOMI. Management. Stone management. No admission. The patient will come as a simple stone, no anuria. If there's anuria, do you admit?
Yes.
100%. No anuria. So no admission. Senior. What are the investigations that you will do? Guys, no. She starts with ultrasound. Blood, urine, stool, image. Blood. Infection marker?
Yes.
Yes, infection marker, urea electrolytes. Okay, you need uric acid. Why uric acid levels? Because some stones. Uric acid, yeah? Calcium levels, phosphate, again, stones. In urine, diabestic culture, and stool, anything? No stool. Then go to scan, ultrasound, and CT, KUB. So start with the ultrasound, KUB, and they can do CT, KUB done. Don't start with the scan, please. Start with the blood and urine. Blood, urine. Then scan, okay? Now, step 4 is, look, if you always, once you reach management, you follow the steps, you're not gonna miss anything. Step 4 is symptomatic and lifestyle. Symptomatic. Painkiller. Painkiller. If there is dehydration, but there is no dehydration because no admission, no dehydration is like, if the patient is with the stones back home in Egypt, any stone, come, ketolac, IV fluids, but here is no. I mean, you understand? If the patient is dehydrated, if he's not drinking, yes. But not every single patient with stone, I will put cannula. No, okay? So, painkiller, you can give diclofenac. And ask him to drink plenty of fluids. plenty of fluids. Pain relief, plenty of fluids. So symptomatic and the lifestyle. Symptomatic and lifestyle. What is the lifestyle? Whatever he told you. Dehydration,
Smoke.
diet, whatever he told you. This is management of a stone that as simple is back and forth the pain. The patient is fine, he's not dehydrated, no anuria, everything is fine. However, if you go back to lab 1, depending on the size of the stone, if the stone is less than 5 millimeter, if the stone is less than 5, so just wait and watch and ask to drink plenty of fluid and that's it. This is the case I gave you now. But if the stone is 5 milli up to,
1 centimeter.
so then you can do electric shock or laser. You can do the laser, okay? Or if it's bigger or if it's not working, you can do surgery. But depending on the stone size. So what we're gonna do in this case is simply, if the patient is fine, if the patient is not dehydrated, normal, back and forth, everything is fine, you mentioned scan and you got the size of the stone and it's less than 5, nothing. Wait and watch, plenty of fluid, safety netting. However, if it's a bigger stone, then you can tell him that we can have a procedure where we can break it with laser, as simple as that. Don't say to him electric wave, lithotripsy, no, as simple as some laser to break it down. You are talking to the patient, okay? You don't need to tell him medical terms, you know that, okay? So if the stone is bigger stone, the management will be different. If the stone, if you get given a size of a stone bigger, or if the patient is having anuria, what is the management? Sorry? You see, I don't like to start like this. Admit,
Admit.
please.
Discuss with senior.
Admit,
Senior.
discuss with senior. Here,
Blood.
cannula and bloods, take blood, give fluids, you know, here, IV, okay? And these patients, here you will talk about the procedure, which is either shock wave, either laser or
Surgery.
surgery. Clear, guys?
Yeah.
Clear. Okay, and investigations again is the blood, ultrasound, CT, KV, urine.
Other indication for admission?
Sorry?
Other indications for admission?
No, indication for admission is,
Only two?
Do we need to remember the drug name for specific stone?
sorry?
Do we need to remember the medicine for specific stone?
No, the medicine will only have tamsulosin,
Yeah.
okay? What is the, why do we use tamsulosin?
Relaxation.
Tamsulosin relaxation.
Prednisolone
Non-steroidal.
And prednisolone for
increase inflammation.
the inflammation. There is a stone in the ureter. This stone can block, can what? Block, and it can cause inflammation. So you can give two things. Tamsulosin to relax the ureters, prednisolone to decrease the inflammation in the ureter.
Oh, diclofenac, of course.
Okay, diclofenac as a painkiller. Okay, so as simple as you will put the patient on a drip, fluids, the medication, if you will give medication, 2 medications, tamsulosin to relax your ureter, tell him, that's it. And prednisolone to decrease the inflammation. And as simple as if you're gonna do procedure, it will be
Surgery or laser.
surgery or laser, that's it.
Safety.
Okay, and always sympathetic.
CT scan
Now,
specialist.
sorry,
Specialist will use CT scan.
I said ultrasound and
CT.
I said.
Okay, also specialist.
No, you in the hospital. You are in the A&E, you can do, guys, there is one thing you need to know. In the A&E, you can do anything. If the question said A&E, you have X-ray in the A&E, CT scan, MRI, everything is in the A&E, okay? Now, some food or some things that related to stone. What? Chocolate, red meat, nuts. So if the patient mentions to you chocolate, nuts, or red meat, okay? These are all things that's related to stones. Just in case he drop, I love doctor, I'm from Egypt, and you know, we love chocolate back home, but we don't have good chocolate, or chocolate back home is inexpensive. So when we come to UK, we eat too much chocolate, you know, you can advise him. Brother, don't worry. Nobody will take that chocolate from you. Nobody will grab it. You are in UK now. Do you have visa? You will say, yes, I'm resident here. So don't worry, relax. You're going to have a chocolate for this and for that. So chocolate and
Not red meat.
nuts and
Red
it's
meat.
everything that we don't have back home. We have back home, but people struggle today. So chocolate, nuts. I'm talking about the Ain Shams people. I'm talking about the village people. Right? So chocolate, nuts, and what else?
Tomato.
Red meat.
Sorry? Red meat.
meat.
Again, red meat in Egypt. We do have red meat sometimes. Okay, next. Next is UTI and BPH. It's another case. A patient, the previous one was gas filter. The previous one, stone. The one before that, UTI, female. This one is UTI male. UTI male. But there is a risk factor which is BPH. So it is UTI and BPH in one case. UTI, in one word, I will ask about urine. BPH, frequency. When he goes, difficult to start. When he start, very weak. At the end, terminal therapy. That's it. This is the case. And always exclude
Flows.
cancer. Because BPH, cancer. That's the station. So the station is kidney, which is urine, and BPH and cancer. That's clear? Once you stop there, you can ask in other differentials. Anyway, the question is, you are an FY2 doctor in the surgical department. Andrew Thompson presented with lower abdominal pain and fever. Lower abdominal pain and what is lower abdominal pain and fever? UTI. Think of it, infection. But in this patient, it's a mixed station. Mixed station means there is another risk factor here. There is another problem here when you take history, which will be prostate. If you go back to the structure, you're going to be lost. I said, whenever we talk about genito-urinary or abdo pain, I said how many systems you should think of? 3 in male and 3 in a female. What are the 3 in male? Look at me. GIT, kidney and let me genital. BPH, prostate. In a female, GIT, kidney, female genital organ. Clear? So either female genital organ or BPH. This case is UTI, BPH. How can I help you, Mr. Thompson? Doctor, I have pain while passing urine. First thing to do, P1, pain while passing urine, or lower abdominal pain. Socrates. Site, onset, character. Okay? He will give you the presenting complaint of lower tummy pain. That's it. Lower tummy pain. Anything else? Yes, doctor, fever. Explore. So lower tummy pain and fever, these are the presenting complaint. First thing to think of, urine. If you want, tell yourself, it's fine. So you don't get lost. Tell yourself, how many systems, yeah, brother? 3. So you can ask him from the start. Any vomiting or diarrhea? No. First system. Any change in the color or the smell of urine? Yes. Yes, so stop. Yes, so stop. Color urine, explore. Smell urine, explore. Blood in urine, explore. And when you finish your urine, that's your kidney. What is the third system? Male. Prostate. Go on the prostate, he's positive. Station is finished. So any patient is coming with lower abdominal pain, or any patient coming with lower abdominal pain, if it's a male, 3 systems. What are they?
Urinary, prostate,
Kidney, in one word, urine. GIT, nausea, vomiting, diarrhea, prostate. If it's a female, GIT, kidney, and genital system. As simple as, if I'm asking about the GIT, nausea, vomiting, diarrhea. If I'm asking about urine, kidney, urine. If I'm asking about the female genital organ, STI, sexual history, discharge. If it's a male, prostate, not a prostate symptom. So this case is lower abdominal pain, explore, fever. Then he will give you presentation of BPH. Doctor, frequency, then go there. Frequency, which stream, and the station is finished. You want to add something to it? Flows, to exclude? Guys, please, relevant history. Please, relevant history. Please, relevant history, okay? So, after asking about the symptoms, the patient will give you positive BPH and positive UTI. That's it, this is the case. Now, don't forget to exclude cancer. Cancer by flows. weight loss, lethargic, yeah, appetite. Okay? Now,
What are the causes?
now I know it's UTI. History is finished. Now I know. I said the case is UTI and PPH. Now, UTI and PPH. What is the complication if I'm thinking of UTI? Yeah, pyelonephritis. Don't forget pyelonephritis because the case I told you the topic. UTI, PPH. So the cause and complication. The cause we know. The cause we know. Why bring back to front? Why bring back to front?
No,
No, why? You told him no, he said no. He's gonna hate me after. He's gonna hate me.
Male.
Male, أيوة يا brother. Male, yes, male. So no wiping back to front, no tight underwear because male sometimes wear tight underwear. Okay, so be careful. It's a male. So presenting complaint, make sure you exclude pyelonephritis. Pyelonephritis. Make sure you ask about rigors, shivering, anuria. Okay, and PPH complication is cancer, which you asked already about weight loss. Yeah. Now, examination. What would you examine? By the way, what else when you go to P1, you explored the P1, and P2, you went into, don't forget, yeah, P2, P3, DESA. What's important for you in this case in DESA? Smoking and alcohol. Exercise is not important. Diet is not important. Diet is important in stone. It's not important here. Okay. In maftosa. What is important? Math. Family history is important? Yes. Of cancer or prostate problem. Allergy and medications. Clear? And this patient will be known PPH, so he will tell you I'm on tamsulosin and what? Finasteride. You know, any patient who is PPH, they are on two medications, tamsulosin and finasteride. Okay, clear? Tamsulosin for what? Relaxation. Because the prostate is closing the urinary system. So tamsulosin for relaxation and finasteride for shrinkage of the prostate. Shrinkage, yeah? Unlike tamsulosin and prednisolone, in which case? Stone. Tamsulosin for relaxation of the ureter. Prednisolone for inflammation of the ureter. Brother, clear, brother? Clear from your heart? Which part? Left ventricle or right ventricle?
Left ventricle.
So, don't forget, the patient will tell you he's on tamsulosin and prednisolone. Then now, management. How to manage? How to manage? Management? Do you want to admit the patient? Okay, no, it depends on the history. If the patient does not have complication, if the patient no complication, UTI, simple UTI, but there is a presenting complaint with a PPH, or known to PPH, is it indication for admission? No. So, no admission. However, you can admit if the patient is not passing urine and urea, and you know, but this patient will be referred to urologist. So number one, no admission. If the patient is stable, no problem. Senior, investigations. What are the investigations in this case?
Blood,
Perfect.
urine.
If you take this from today from just the blood, urine, stool image. Blood. What are blood inflammatory markers? Full blood count, kidney function, sodium, and you can even do PSA, prostate specific antigen. Urine? Yes. Dipstick, culture, and then stool? No. Image? Yes. Scan on the bladder, ultrasound, KUB, CT KUB you can, okay? And scan on the prostate. You wanna see scan, okay?
So we can do this in the GP clinic?
We are here, not in GP, we are here in the hospital.
Okay.
But in a GP clinic, can you do it?
You can do it.
In a GP clinic,
Okay.
you just take blood,
Okay.
ECG. And when you take blood, the result comes 2 weeks later. You can come to discuss the result. But in a hospital, 3 hours later. Clear? Okay, because the GP, they take the blood and they send it to the lab.
Oh.
And then they tell you, come for the follow-up. So they cannot have acute case in GP. Okay, anyway. So I said the blood and the scans, and then we said step 4 is symptomatic. What are the symptomatic? Painkiller, pain, painkiller, UTI, don't forget, it is UTI. It is what? Don't forget, don't let the PBH confuse you.
Yeah.
It is UTI. PBH, you will do nothing about it. Urologist, you are here UTI. So fluid, painkiller, antibiotics.
No.
Guys, there is UTI, there is infection.
Yes.
That's what I said to you, do not confuse yourself. This case is
Urinary tract infection.
because of
BBH.
PBH, you will do nothing about it. Your job is to manage that.
UTI.
PBH is urologist
Yes.
problem. Are you confused?
No.
No.
Okay, because he has fever. The guys have fever. So painkiller, plenty of fluids, antibiotics. Advise about any risk factor, and then you will refer him to urologist. And the urologist, if the patient is new BBH, he will give him tamsulosin and finasteride. And it can be later on. It can be later on an indication for surgery, elective surgery. Clear? You see how simple I mentioned?
I have got one case that from consultation UTI. I'm thinking about if I can inform her to come just for because antibiotic I couldn't give
No.
her antibiotic
Yeah.
by phone. So
Yeah, there are simple UTI that you
yeah,
don't
but-
even, guys, UTI, I've mentioned it in day 43 in the old course.
Yeah.
There is simple UTI, as simple as plenty of fluid, paracetamol.
yeah, we can do that.
Yeah, there is UTI, GP antibiotic, there is UTI hospital,
Okay.
pyelonephritis, clear. You can have UTI, you can manage it in 3 different ways. A patient can, hi doctor, how are you? I'm just, having, some, stinging while passing urine. And are you fit and well? Any fever? No, just stinging while passing. Do you want to bring her?
No, fluids and paracetamol.
Plenty of fluids, painkiller. Doctor, I'm feverish, pain while passing urine, bring here, antibiotic. Doctor, I have not passed urine, I'm shivering.
Acute
Hospital.
condition.
Anyway,
Arthritis.
back to this case now so we don't get lost.
Okay.
This case is UTI, painkiller,
Antibiotic.
fluids, antibiotics. Do not forget. Because of what the UTI?
Because
BBH.
BH, so urologist
Referral.
who will give you some medication, like a medication to relax the ureter, which is tamsulosin, another medication for shrinking the gland, which is finasteride, and you can be an indication for elective
Third.
surgery, which is third. Okay, now, and always safe to treat the patient for sepsis or because one of us. Next station, hematuria. Next station is hematuria. Okay, 55 years old. Anthony Thompson presented to the hospital with blood in urine. So, what is the case? Blood in urine. This is the presenting complaint. How can I help you? Doctor, I'm having blood in urine.
What do you mean by blood
This is
in
the
urine?
presenting complaint. Yes, so explore.
What do you mean by blood?
What do you mean? And because it's blood in urine, you need to ask about the amount. What do you mean the amount?
fresh or
Yeah, because you want to see is it fresh blood coming or
At the beginning, at the end?
at
or
the beginning of it,
at the end?
during,
During.
or after you finish passing urine.
Okay.
Are you lost?
No.
I'm all focusing on exploring the complaint because you guys panic. Panic why? I want to start to differentiate. I want to start. So that's why you take the presenting complaint not serious because you want to start
The disease.
asking. I want to start asking the patient things that he doesn't have. And I don't focus
On what he has.
on what he has. So when a patient is coming with, doctor, I'm passing blood in urine. Tell me more about it. When did this start?
Once.
How did it start? Is it all of a sudden? Is it increasing?
Is it coming out of-
You've mentioned to me blood while passing urine. Do you mean that at the start of passing urine you pass the blood, or throughout, or at the end? Because every single
Things.
thing is something. If the blood is at the start, you think of
Urethra.
urethra because it's pushing blood. Could be trauma. If the blood is at the end, bladder,
Bladder.
cancer, something from the top. Clear? So this is the presenting complaint. So I'll ask the patient, is the bleeding at the beginning? Is it at the end? Is it throughout? Okay? Clear?
Yeah.
And track timing, Because there is blood. I said any discharge track.
Track.
Timing, relation. Have you had any? Procedure? Yeah, any discharge, I said explore it using a track. T for timing, R for relation. Is it related to anything? Is amount, C is color, and nature, always. So when I ask in this case there is blood in urine, you need to ask about timing, you need to ask about relation. What is the most common cause of blood in urine? Relation. Relation, what do you mean? Is it related to trauma? Have you had any trauma? Or any procedure? Can lead to blood. Yeah? Now after exploring the presenting complaint, apart from blood in urine, anything else, yeah, brother? Yes or no? Regardless. What are my differentials? I said blood in urine. Where is the urine coming from? Kidneys. I said kidney, ureter, bladder, urethra. Kidney and ureter and bladder and urethra. In every single location. You could have an infection, you could have a stone, you could have cancer. Clear?
Yes.
So, in the kidney, you can have an infection, which is pyelonephritis, fever. End of story.
Vomiting.
Fever everywhere, by the way. Yeah.
Okay.
You can have stone, which is when you ask about when the patient is coming with blood in urine. Logic to ask what? Any fever? Any pain? Yeah, if a patient is coming with blood in urine and they already explored the blood in urine, track and timing, and is it at the start, at the end, throughout, what is the most logic two questions? Fever and?
Pain.
That's it. Fever and pain. Do you agree with me?
Yeah.
Guys, be simple, be natural. Fever and pain. Okay? Then, when I go to differentials, these are my differentials. Kidney, ureter, bladder, urethra. In every single location, you can have what I said to you. So in the kidney, you can have cancer, adenocarcinoma, you can have infection, you can have a stone. But be careful, because in Plaque 2, we make a very common mistake. When we are revising with Dr. Fatima before the exam, when we revise, during your revision before the exam, I'm talking about before the exam, we always think of the differentials by the medical term. So we always revise like this. Always. We always revise like this. Okay, if a child is coming with fever, I will think of meningitis. I will think of chicken pox. We all revise like this. Then you go to the exam. How can I help you, Hagga? His mother. She said to you, my son is having fever, doctor. So you tell meningitis. So rash, shy from light. Is he having any rash? No. So you always translate in your head the symptoms. You understand? You always translate it from a condition to symptoms to patient.
Takes time.
But always when you revise, the best way,
Listen.
when I tell you, what are the differentials if a child is coming with fever? What's your differential? Yes. No, differentials. A child with fever, you must exclude.
Meningitis.
Don't study like this. Don't study meningitis. Say rash, neck stiffness, shy from light. Understand? Always think of
Symptoms.
symptoms, please. Whenever you have any of your colleague ask you, for example, a patient is coming with pain or pus in urine, don't say to him UTI. Say to him urine color, urine smell, because that way you are going directly into what you will tell the patient. You don't say UTI and then in the exam you think of what are the questions I will ask you UTI. Then you think of it. Then you lose the eye contact. Then you think I did well, but in fact in the cubicle you are thinking, you're wasting your time and you are looking in the, clear. Okay, because I am the one when I study myself, if you ask me a question, I always used to look and talk. But I started learning on looking at your eyes and as if I'm looking there. Seriously, that's me. I made plenty of mistakes when I was preparing for Plaque 2. One of them is I studied by myself. I did not have a study partner at all, no study partners. Number two, I was thinking of not of symptoms. I always used to do this as condition, and I had this mistake of I can't because I'm translating in my head meningitis. What are the questions? But if your friend asks you what are the differentials for such a condition, always give him symptoms. Anyway, so in this case, we've mentioned blood and urine. Don't forget, I said to you, whenever you think of infection anywhere is one thing, fever. Cancer anywhere, flows. So by asking the flows and by asking fever,
And excluding a lot of
infection and cancer, okay? So you need to ask about, so infection, cancer,
Stone.
and I said stone. And the stone you can ask about, learn to grow. So these three things, anywhere, cancer, stone anywhere, infection anywhere. Now, I have mentioned that kidney, infection, cancer, stone. Ureter, infection, cancer, stone. Bladder, again, infection, cancer, stone. And then I said urethra, as simple as trauma
procedure.
or procedure. Okay? Now, that's my P1, my P2. DESA, in DESA, what do you want in DESA?
Medicine.
Smoking, in DESA. Smoking and alcohol. When you go to Maftosa, what do you want?
Blood thinners.
Medications,
Blood
blood thinners,
allergies.
bleeding disorder,
Family history.
family history of
Bleeding disorder.
cancer. And don't forget, before you ask the word cancer,
Occupation.
signpost.
Signpost.
Yeah.
I'd like to ask you some questions
I might
that may
find-
sound alarming. Please bear with me. Boom. Yeah? Examination. Examination. What would you like to examine? Verbalize, obviously. Abdomen and observation. Anything else?
Thinking about
Prostate.
Perfect. Back passage, yeah? Back passage.
Or prostate.
Yeah.
Sorry? Yeah, back passage. Always think of the back passage if you are suspecting
something.
cancer or something like that. Always
But he
think
didn't
PR.
give symptoms.
Sorry?
But he didn't give symptoms of enlargement of the
So,
prostate.
by the way, in the hospital, any abdominal problem, always they do PR. Because even though he didn't mention symptoms, but it could be something early.
It's a part of
Yeah,
Yeah, all the time, guys. All the time. Whenever you have a patient with abdominal pain, equal PR. Okay? Provisional diagnosis, whichever cause is mentioned. Yeah? Whichever cause he gave you. But in this case, in these cases, there is a station, blood and urine, and the cause is bladder cancer. In Black 2, there is a station, blood and urine, and the cause is. So when you ask him, there is family history,
Smoking.
there is smoking,
Occupation.
there is occupation.
Okay.
Okay? Then you are thinking of bladder cancer. Provisional diagnosis. Can you tell him cancer?
No, first best
Okay.
case
So
scenario.
best case scenario and worst case scenario. Okay? So you cannot tell the patient.
Anything. Anything.
Sorry? Sorry? Any?
The job.
Dies.
Yeah, die.
Exposure
Yeah.
to dying.
Yes. Okay? Aniline die. Yeah? Club one question.
Yes.
Always, you know, this always club one. Yeah? So, yes. So be careful because in these cases, if the patient is coming and is giving you smoking history, is giving you occupation, working in aniline dye, okay, and sometimes factors for plastics and stuff, okay, it is a risk factor. Family history is a risk factor. Don't give diagnosis of cancer. In these cases, you will give
Best scenario.
best case scenario and worst case scenario. Okay. Okay. What are the two cases that can come? And I think of when the patient is telling, give me blood and urine, always think of prostate cancer
And urinary
and bladder cancer. Okay? Prostate and
bladder cancer.
bladder cancer. And if you think of bladder cancer, how will the station go? Normal. Blood and urine, explore. When you go to ask about flows, is positive. When you ask about risk factor, smoking and occupation. Clear?
Okay.
Now, when you go to provisional diagnosis, prostate
Worst
cancer,
case-
what is the case, best case scenario? Worst case scenario. Okay? Best case scenario, you can say there's an infection somewhere. But worst case scenario, I'd like to exclude
Anything sinister.
anything sinister. Okay? Now, management.
Urgent referral.
Admit.
Management is urgent referral. 2 weeks referral to
To urologist or oncologist.
urologist. Okay, so urgent referral, 2 weeks referral. However,
I will not admit.
what will they do? What will look, guys? Cancer patient. If you admit them, what will you do?
No.
What will you do if you admit the patient? Like,
Imaging.
so for example, if this case is a GP clinic,
It's a GP, okay?
okay, okay, even if it's in the hospital,
I will not admit.
yeah, in a hospital, if a patient is fit and well and you know he's giving you symptoms,
Too urgent only.
urgent. But what will you do if you suspected cancer?
Nothing.
You tell me what will you do? You need to do further investigation,
Investigation.
but by the specialist.
Okay.
Yeah.
He is the one. That's why it's always urgent referral. You never admit patient with cancer unless like he's coming with you coughing blood and you know shortness of breath and
Codeine or something like that.
something like this and cancer. Yes, admit.
Okay.
But if a patient coming, doctor, you know, I'm having some, for example, chest pain, or I'm having like you know some cough for about 3 weeks. 60 years old, having cough for
3 weeks.
3 weeks, and then when you take history, you are suspecting cancer.
Okay.
Any shortness of breath? No, just cough.
Come out.
Any blood? No, just cough. Then you do X-ray. You see in the X-ray you see
Nodule.
shadow.
Okay.
What urgent? Why would you admit him?
Okay. Okay.
Nothing, just urgent refer to respiratory. Anyway, so in this case, the patient, if he's unstable, admission. But if the patient is stable and all his problem is blood, you will talk to your senior and you will say, I will do urgent referral. And if you are in a GP clinic, would you do any investigations?
But
No, you will not do any investigations.
I'm in blood.
You will mention, I will tell you now, something that you always get mixed up with. I will tell you now, yeah?
Yeah.
So a patient is coming like this case, yeah? Blood and urine, GP clinic. Blood and urine where? In a GP clinic, and he's having blood and urine. Take history, you took the history, suspecting bladder cancer. He's giving you all the factors. You are in the GP clinic. Is he stable? Yes. Doctor, blood and urine. He's stable. No dizziness, just blood and urine. So, as simple as I'll be talking to my senior, because we would like to exclude what we call it worst case scenario, because we would refer you an urgent referral to the urologist. Would you like me to tell you what will the urologist do? Yes, doctor. They will take some blood, infection to check for infection marker, and they will take some blood to check for any tumor marker. They will make some scans, CT scans, yeah? CT scan on the abdomen, chest, pelvis. So I'm telling him about what's gonna happen there. But what will happen in the GP? Nothing. Why? That's GP clinic. Always the case is in the exam. Even if you think in the exam plateau, they never bring a case where you will take blood there unless it's a follow-up. Think about it. Any follow-up case in the exam is always why? There is no lab in the GP. There is no lab. The GP cases, you come, you have a complaint. I'm not thinking of something serious. Anemia. I will take blood from you. The blood will be sent to the lab. Result will come to me online 4 or 5 days later. Then I will give you follow-up 10 days later. Yeah, we found this in the blood. We found this on the thyroid function.
Counseling.
And we will do this. Do you understand? So if I do the same with the patient who I'm urgently referring him anyway, I take blood from him, and
2
then
weeks to come.
10 days or two, he's already going where?
To the hospital.
Urologist. He's already gonna be referred to where?
Urologist.
Would I ask him to come 2 weeks later to check the blood with me? Because I take the blood.
No.
Because in the urologist, in the hospital, they will take the blood 2 hours later result. Do you understand the mechanism of it? That's in UK. In UK, if a patient is coming and giving me thyroid problem, like, doctor, I'm sweating a lot, and take blood, and come back later for follow-up. 10 days later, brother, you have thyroid problem. We can refer you to endocrinologist. Doctor, I'm tired. I feel tired. Take blood. 2 weeks later, the patient will come for
The results.
follow up. Then you have anemia. We will give you iron. That's why all your cases in PLAB2 in the GP clinic is always follow up blood result. He came to the Allman clinic. They found the blood. He's coming for the blood. She came for a discharge. They took the swab. She's coming for the swab result. Tell her. He came 2 weeks ago. He's having lymphadenopathy. They took blood, HIV. Discuss result. This is the cases. Why? They say 2 weeks, discuss result. Because that's what happened in the GP. The GP does not give you the blood in 1 day. But if the GP is suspecting something urgent, he will refer you. I mean, why would I let you wait for 2 weeks? I mean, no, refer right away. And when you get referred, you mention the investigation there. So in this case, I hope I did not make you get lost. So in this case, urgent referral to urologist. Where they will do? They talk about blood, talk about everything. Scans, they. But if I take blood from you, and I tell you come 2 weeks later, in 2 weeks you will be there having your blood result in 3 hours. Clear?
Yes.
So when in a GP clinic we say blood and follow up in a cold case, thyroid, anemia. That's why in all your PLAB 2 questions, they always give you the scenario of a follow up with result. He went, they took the blood, and 2 weeks later result. He's coming to you in a GP clinic. Okay? We have a whole topic about test result stations. And all of them, this is what I tell you. Come to the GP, he's suspecting something not really serious. Yeah? Take blood, 2 weeks later come, we'll discuss. And 2 weeks later, if I'm suspecting that you need to go to I send you to endocrinologist. Okay? So in this case, urgent referral to urologist, who will do scans, CT, CTKUB. Yeah? And they can take blood. So blood, CTKUB, and also, because this case is bladder cancer, yeah, we suspecting that they will do cystoscope, which is a camera test, which is what? As simple as camera test, where they will visualize and they will take samples. Clear? And safety netting because there's bleeding, if you feel tired, lethargic, if you know. Scenario 6, 25 years old, James made an urgent appointment. Talk to him, address his concern. 25 years old, James. This case is testicular swelling. Is what? That's it. Testicular swelling. And this case is mixed station. When I say mixed, I mean combined, I mean examination. So in this case, they always tell you 25 years old, Andrew came to the GP clinic with testicular swelling. Talk to him, do relevant examination, address his concerns. So what is the structure here? 242. Please do not forget that in this case there is testicular examination, and testicular examination we discuss it in the academy about how to examine. But make sure it's 242. 2 history, 4 examination, 2 management. Okay, how can I help you? Doctor, I have noticed that I have swelling in my testicles. What is the presenting complaint? Swelling in my testicles. Explore. Explore what? The swelling. So any swelling, you always ask, since when? Is it increasing or decreasing?
It comes and
And
goes.
always when there is a swelling, ask how many?
Yeah.
Is it 1? Or is it more than 1? Always ask any swelling anywhere else. So whenever there's a swelling, ask about how many and
there are others.
swelling anywhere else. Don't ask him, is it cystic or solid? Because some people do. Brother, this is you do in the examination, when you examine. Okay? So, how can I help you? Doctor, I have swelling. Since when? Is it increasing? How did you find out about the swelling? How many? How?
Many are there.
Any swelling anywhere else? Clear? After exploring the swelling, always ask about trauma. Why trauma?
Maybe it's hematoma.
Maybe it's a trauma, maybe like it's a trauma, so there's a swelling.
Okay.
Always ask about fever, pain. Guys, relevant, that's what I mean by relevant
Question.
history. Relevant swelling. So pain, trauma,
Redness, swelling.
Fever.
and what?
Redness Hotness.
Well, I don't. These are finding in examination.
Okay.
Redness and hotness is you finding it. You don't ask him about any hotness, any any redness, any no. Okay. So pain, fever, and trauma. Again, please, guys. Pain, fever, trauma. Very important 3 questions. Okay? Pain, fever, trauma. Then, because it's a testicular problem, testicular swelling, make sure you ask flows. Why flows? Why? Because you're suspecting cancer. So that's one of the differentials. Any other differentials of a testicular swelling? Guys, hernia. You ask him, is it there all the time, or when you lie down, it reduced? Why? Because swelling, it could be hernia. When they lie down, it goes back. So hernia. So always ask him about, is it related to position? One question. Does it go away when you lie down? And ask him about, when you were young, have you had any problems in the testicles, congenital? Okay? And always ask about what? Sexual history. Testicular. Always ask about UTI history. Testicular. Yeah, you forgot, yeah? You forgot?
Sorry?
Huh? Testicular problem.
Yeah, we have to.
Sexual history, urine history. Okay, so I will just any tissues, guys?
Here.
I will just. By the way, it's all about being relevant. Yeah, don't just ask any questions. Okay. What is the complaint? Sorry. What is the complaint? Testicular. By the way, we all know that it's a very important question in the exam, yeah? Anybody has a doubt? Testicular problem, all the time. So, testicular swelling. I will give you the 10 questions. Ask them and you finished. Okay? First question. Since when? Yeah? When did you find out? Is it what? Is it increasing? That's the P1, yeah? The swelling. Since when? Is it increasing? Or is it the same since you found it? What else? Any swelling? Anywhere else? And before any swelling anywhere else, how many? So, since when? Is it increasing? How many swellings? Any swelling anywhere else? How can I help you? Doctor, I have mass on my breast. Which one? The same in the testicle. You can say which one. Is it both testicles?
Yeah.
How many testicles do you have?
2.
Any pair?
Compare.
Compare. So if the patient is saying testicular swelling, you can say
Which one?
which one? How many? Anywhere else? How can I help you, doctor? I have breast swelling, breast mass.
Which breast?
Which breast?
And how?
How many? Which breast? How many?
Swelling, any swelling? or-
The swelling
Anywhere else. Doctor, I have a swelling on my ears. Which ears? How many? Anywhere else. Doctor, I have a swelling on my nose.
لا ما في شو واحد.
But I must tell this. So, testicular swelling, since when? Which one? One or both? Anywhere else? And how many? Then you can ask about pain, fever, trauma. Pain, fever, trauma. Then you can ask about when you lie down,
Does it disappear?
does it decrease or does it go away to exclude hernia? Then you can ask about sexual history. You can ask about pain while passing urine, change in the color or the smell of urine to exclude
UTI.
UTI. So sexual history, UTI history, the position for the hernia, pain, fever, trauma, explore the swelling. And then you can ask about smoking, family history, yeah?
Trauma.
We mentioned trauma, yeah? So smoking, family history. What else should I ask about?
Trouble and descendant testis, you did not ask about.
Congenital anomalies. Okay? Guys, this is what we call it relevant history. No more relevant than this, and you can finish it in like 2 minutes. 1.5 minutes. Relevant history.
Okay.
Why did you only give us as relevant like this? Because it's a combined station. So I want you now to be trained on how much?
2 minutes.
How much? That much. To the point. Pain, fever, trauma. Does it go when you lie down? Sexual history, smoking, family history, congenital. Select. Then, after 2 minutes, you will what?
Examine.
You will examine. So guys, most of our stations are history taking. So that's why we take long history. But if the question said examine or assess or do relevant examination, so that means that you will take 4 minutes examination. So your 8 minutes will be 2 minutes history, 4 minutes to examine, 2 minutes to manage. So in this case, this is how much history will take. Okay? So 4 minutes examination, we all like done the examination in testicular examination here, so you know, okay? Then management. What is the management that you will mention here? What is the management if a patient is coming with testicular swelling, 25 years old, testicular swelling, and like he's like found that you are suspecting cancer, for example,
Referral.
So-
Referral.
senior? Guys, would you do blood in the GP clinic or would you no?
No.
So urgent referral, okay, to where? Urologist.
Urologist.
They will take blood, they will do scans,
Sample.
okay? So they will take blood, they will do scans, all right? And in the blood, what blood you must mention? Tumor markers, yes, and infection markers. Infection marker, toxic infection, tumor marker. What are the tumor markers? You don't need to mention them, but you can say tumor markers like
LDH.
lactate dehydrogenase and HCG,
HCG.
human chorionic gonadotrophin, and lactate dehydrogenase, but you don't need to mention them.
Yeah.
You don't say
Just
to them
tumor
like
markers.
just tumor markers, okay? And sorry, AFB, okay? So alpha fetoprotein,
Alpha fetoprotein.
okay? So alpha fetoprotein, HCG, and okay?
Lactic.
So you can do blood, you can do scans. Brother, how are you?
I'm showing our new colleague his first day at the academy.
طب we can show him the downstairs like عامل ايه يا عسل؟ السلام عليكم. اخبارك ايه؟ حبيبي.
Sorry for interrupting.
يا باشا انت اتقربت اني تايم يا باشا. اني تايم.
Thank you.
بص كوميونيكيشن سكيلز خلاص كده.
King of Liverpool.
حبيبي. So scan. Guys, investigations. What are the investigations? Blood, urine, stool, image. Bloods, infection marker, infection and tumor markers.
Tumor marker.
Urine, yes. Urine, then stick culture, and then stool, no. Then image, scan. But because you're suspecting cancer, guys, scan on the testicles, ultrasound, and CT scan abdomen and pelvis and chest X-ray. Why?
For staging.
Metastasis. Because that you have referred them, they will do so. Okay?
And not biopsy, take the testicle of them.
Yeah. Can you take biopsy from testicle?
No.
Testicle, either take it or leave it.
Excision.
Yeah.
You cannot. No, there is no biopsy from testicles.
Excision.
No, guys.
All of it.
Guys.
Excision of all of it.
Yeah, excisional also.
Excisional.
I hear that. Excisional, you can take it.
Excisional.
But I just like to so that testicle either take it,
Leave
but you cannot take a piece of it. Okay?
Yeah.
Yeah.
Spread.
Now, there is another case that epididymoorchitis. How can I help you? Doctor, I have pain in my testicles. So what is the presenting complaint?
Pain.
This case, it's not examination case.
Okay.
What if it's examination case? What is the only difference? If it's examination case, if they said to examine, 2 minutes history. But if there is no examination, take your time. Yeah. Anyway, how can I help you? Doctor, I have pain in my testicles. What is my P1? Pain. Explore Socrates, please, in details. Where exactly? Site. How did it start? Character. Type of pain. Does it go anywhere else? Have you taken any painkiller for it? In details. Okay? After Socrates. Apart from this, anything else? Fever, doctor. When? Did you measure it? Did you take anything? So, fever. Okay? Anything else? Discharge, doctor. So, the presenting complaint of epididymoorchitis is what? Pain, fever, discharge. Discharge. How to explore discharge.
Right.
Track. Timing of the discharge. Relation to anything. and amount of discharge and color is there any blood in it.
Yeah.
These are the three presenting complaint for epididymo-orchitis. Pain, fever, discharge. After that, I will go to differentials. My differentials are what? Or the questions I want to ask, or the differential or the questions you must ask about urine and
And
sex.
urine, yeah.
Why do we use the penis for? Two things. Urine and any other use? No. So urine history, sexual history. In details. Any pain while passing urine, smell urine, color urine, blood urine. One word, urine. I'd like to ask you some questions that may sound intrusive. Yes, doctor. Sexual history. Are you sexually active? Do you practice safe sex? Stable partner or not? Okay? Because epididymo-orchitis, risk factor is sex. Unprotected sex. Clear. So always remember, in epididymo-orchitis, I will ask about urine and sex. You can ask the rest of the questions. And P2, have you had any problem in testicles before? Have you had this before? And any medical condition? He's 25 years old. So as simple as, are you normally fit and well? Yes. P3, DESA. In DESA, you remember lifestyle, we always say P3 is DESA plus or minus what?
Yeah.
IV drug abuse and sexual history. So in this case, do you need to ask about diet? No. Do you need to ask about exercise? No. Do you need to ask about smoking? Yes. Alcohol? Yes. And sexual history, which is sexual plus IV drug abuse. Why sexual? Why IV drug abuse? Because sexual and drugs,
Yeah, they are
if you have a STI, it's a bloodborne, yeah? Clear? So that's why we say P3 is DESA plus or minus IV drug abuse and sexual history. In this case, both of them. You see, Dr. Fatima, how you take relevant history, not any history, relevant, because that will save my time in management. And then in Maftosa, what is important in Maftosa?
Medication.
Yeah, medication,
Allergy.
allergy, family history, and travel
Travel,
history.
yes.
You know from Plab 1. Where did you go? I went to Spain, Legionella. What about you? I went to Thailand, STI. What about you? Businessman went to France, STI. You know Plab 1? Plab 1 is like countries. If you go to Spain, Legionella. People actually like, go to Spain, Legionella. Huh? Yes, if you go to Egypt or Sudan, all the time in Plab 1, in Plab 1, yeah, that's how we all pass Plab 1 like this. 25 years old, Spain, Legionella, right away. Seriously, nobody carry on. Understand? 25 years old, pain in testicles, surgery. Urgent. Understand? Huh? Seriously, that's how we all did Plab 1, you know? India, you understand? And then they tell you, 25 years old has been to Thailand and he developed abdominal pain. But you saw Thailand, you check the STI, you get STI. But later when you carry on the question, abdominal pain. You understand? And then you find out it's gastroenteritis. Because they eat as well there. They don't just have sex in Thailand. They eat, you understand? So, understand? Seriously. Anyway, so I'm just telling you that please be thorough. Don't just like, you know, because some people, they always like, because they know the stations. We cannot handle it by just showing, we know the station, you know, like, no. Try to be thorough, yeah? Any patient with pain, trauma, any patient with problem in the testicles, sexual history, and UTI history, you know? So that's my relevant history in epididymo-orchitis. Sexual, urine, travel, IV drugs, and they explore the 3 symptoms. Management, examination, testicular examination, yeah? Then, provisional diagnosis is what? How would you claim epididymo-orchitis? Infection. Okay? In your testicles, alright? Then management. What is the management?
Yes, so
Guys, 7 steps.
Begin with the beginning.
No admission, nothing. Failure, yes.
Yes.
Investigation. What are the investigations? Blood, urine, stool, image. Do you want to do blood?
Yes.
Infection markers?
Yeah.
Yes. Do you want to do urine test? Yes. And in the blood, you need STI screening. Wallah, if you don't mention STI screening, at your own risk. STI screening because you're suspecting this is unprotected sex, and you know. So STI screening for the rest of the STIs, okay? And so that's urine stool image, scan. You can do scan, okay? And then management. Step 4 is symptomatic and
Symptomatic and lifestyle.
symptomatic skin killer, and you need for this patient Antibiotics. Infection.
Antibiotic itself.
Antibiotics. Okay? And what else you need to talk about in safety in symptomatic and lifestyle?
Lifestyle.
The swab,
Guys,
sister swab.
Swab, perfect, but you need to talk here about safe sex.
Safe sex.
Safe sex. Safe sex. Safe sex, okay? And do you need to refer to anywhere?
Can't I just
No.
refer,
Gum
give him
gum
antibiotic and refer him to the gum clinic? And
Yeah,
then,
in this case,
yeah.
because it's related to STI,
Yeah.
this patient can be referred to gum clinic.
And
What?
ask the partner.
Yeah, I said what
Partner
else
identification.
you need to talk about is what?
Okay,
Partner. Any symptoms that the partner has, and if the, but if the partner is asymptomatic, do you wanna bring her?
Yes.
You need to get
Yes.
that.
Yes.
Yes.
It's great.
Even if-
After the result came.
No, no, no.
Even if not
If
symptomatic,
the partner is
we offer-
asymptomatic,
Yeah, refer.
if the partner is asymptomatic again, any STI, any
Encourage her.
Encourage.
What
Yes.
screening, yeah.
encourage. Yeah, you like the word encourage. Encourage. I'm not wrong. Encourage. You know. No, I mean talk about partner. Guys, at any STI, partner. Any STI, any sexual transmitted partner, and the partner can be asymptomatic. Mostly, is the male who is asymptomatic.
Yeah.
Mostly, the female has the symptoms. The male is asymptomatic. But if it's the other, if it's a male coming with symptoms, always ask about the partner. Always the partner, you know, you should come. And what if he refused to bring his partner?
Notification
Notification
program.
offers but
Why?
no
Why?
notification program.
Yeah,
And if
why?
he had
If
HIV,
he refuses, ask him why.
Why?
First, why is he refusing? But it's logic to refuse him. Like, imagine if I could bring your partner because you are suspecting STI, and would you bring
There's a
her?
notification program.
Huh?
Notification
Yes,
program.
yes. Yeah, okay. Yeah. But can you force him to bring his partner if he doesn't want?
that's HIV.
So if he doesn't want to bring his partner, if he doesn't want, عمور. دلوقتي نزلوا احنا. If he refused to bring the partner, can you force him?
No.
No. What is the only case that? But you're not gonna force him, but
Not
nicely,
force.
يعني. You know, politically. You know, what do you think? How do you think? You know, if you don't bring air, what's gonna happen? Risks and benefits. It's HIV. The HIV case is the case when you must bring that, but you're not gonna tell him you must. You should bring your partner. No, doctor.
Give
I
him
don't
some
want.
time.
May I ask why? He will give you a concern. Then we can give him some time to think about it.
Think about it.
She's at risk, risks and benefits. Okay? And the HIV case is the only case that when you tell the patient you don't need support system.
No.
You don't, okay? Your wife, yeah, support, yeah, you can't, okay? So, epididymoorchitis, and epididymoorchitis always exclude mumps, yeah? So always any swellings in your neck, you know, flu-like symptoms, okay? Contact history, travel, yeah. That's it. Thank you very much.
Thank you.
Thank you.
Do you wanna finish something else or?